We'll get started and start on time, and we'll end on time or end early. How about it? So maybe we can go around and do some introductions, because we have some new folks around the room, and we also have some new folks joining us on the phone. And I'm trying to see who. Andrea is not eating anything right now, so maybe if we did a circle around the room. Andrea, would you mind kicking us off and telling us sort of who you are and your involvement in CHORDS and governance, especially for you, and then we'll move over to the phone folks.
Okay, great. So my name is Andrea Polino. I work at Kaiser, Colorado. I've worked on several large network studies, kind of involved in governance and helping create documentation for governance. Currently, the portal network that's funded by CHORDS. I'm involved in CHORDS because Kaiser, Colorado, data contributing.
How about we go this way by Ian, so that, Jen, we give you a sec to get settled. Thanks.
I'm Ian Pelto with CHI, and I'm taking notes today.
Thank you, Ian. And I'm Sarah Schmidt, and I'm on the project team at CHI.
I'm Rachel Zucker. I'm over at the university, and I work with CHORDS mainly on our research agenda side of things, governance and all. I'm Sarah DeKine, and I'm at Children's Hospital Colorado. I'm the manager for the Research Informatics Group, and we're a data partner, and my staff do all the technical stuff.
Greg Budney, Denver Public Health epidemiologist, program manager for the CHORDS side.
Greg, you are like 3 days fresh to this project, aren't you?
I am.
Okay, welcome. And you're also fresh to Colorado?
Yes, I've been here for a week and a day.
Wow, welcome.
Emily McCormick from Denver Public Health, former CHORDS project manager, excitedly former. Still love the project.
I'm Allie Morgan. I'm with the Colorado Health Institute, and I am here as project support staff and especially working on communications and branding so that we can communicate all the awesome work CHORDS is doing with people who may not have as much of a technical background.
I'm Jennifer Barrow. I work at Kaiser with Andrea, and I manage the BMI monitoring project, which is very intertwined with CHORDS.
Would you maybe just give the 30-second what that is for folks who may not know?
Yeah, so it's essentially, I see it as kind of starting out as a pilot for what CHORDS can do in a lot of different arenas, but it's coordinating. Right now we have 5 health systems that bring their EHR data together. The health department is our hub and combines all the data, and we produce maps and data tables that show BMI rates or prevalence in different geographic areas, down to the census tract, and actually down to the block group in a rural area.
Thank you, Jen. And
sure. Jeanette Waxlonsky, I'm the Director of Research Innovation over at Jefferson Center for Mental Health and their Office of Healthcare Transformation, and I'm a clinical associate professor in family medicine, CU. And I believe my role is kind of connecting the mental health centers to this project and being that interface.
And I know we have folks on the phone, and so for folks in the room, we have folks on the phone and your mics are in front of you, and as long as they are green, that means that you're live. If for whatever reason you want to not be live, you just hit the little button in the center and it goes red, and then you mute it. Maybe for folks on the phone, if your name begins with A through L, introduce yourself and tell us who you are and the role you play in CHORDS.
This is Jessica Bondi.
Yeah, hi.
Okay, Jessica, you've got the floor.
Cool. Okay. Yeah, so I work at the university with Rachel, and I've been working on CHORDS for a number of years on the technical side.
This is Al.
Go ahead. We're speaking at the same time.
This is Allison.
Allison, is that you?
Yeah. Can you hear me?
I can. We're getting a little bit of an echo, though, so we're going to do some work on our end to see if we can't take care of that echo.
Well, am I supposed to be connected by the phone or by the computer?
Probably connected by computer. Are you connected by, did you say you're connected by computer?
And phone, I think.
And phone. Maybe one might do it. The echo's gone. We'll see how that works. She gone? Is she gone?
Allison, can you hear us?
Hear me?
Yeah, better. Okay.
Hi, this
Great,
is Allison
thank you.
Shoup. Oh,
You're good.
okay. This is Allison Shoup. I am the Informatics, Health Planning, and Epidemiology Manager at Tri-County Health Department.
Ashwin?
This is Alok. I'm Executive Director at Colorado Alliance for Health Equity in Practice and also working in CHORDS. Glad to be here.
And this is Chloe Bailey. I'm with CCMCN. I'm the Chief Medical Information Officer, and we are a longtime data contributor to CHORDS.
Thanks, Chloe. Anybody else at the beginning of the alphabet? No? Okay.
Susan.
And Susan, I think you're our lone end of the alphabet participant. Since this is your first meeting, would you mind telling us a little bit about yourself, too?
Absolutely. Hi, I'm Susan Moore. I'm the Assistant Director of Health Services Research at Denver Health, and I'm involved in this just because a number of the projects that we're doing are starting to have much closer intersection with large and distributed data networks and thinking about issues of data ownership and data governance.
Okay, so I think that's everybody. Again, as I mentioned, we've got some folks who are on vacation and had standing conference and whatnot, and some people will be joining us for the second half of the meeting also. So we're just going to go with what we've got. The first agenda item is to revisit the charter that I had sent out earlier this week. I did not make copies of the charter because it's long now. It was long then. It's longer now. I just wanted to check in to see if, first off, did everyone receive it in the email? Because you're all here, I assume you have. Just wanted to highlight a couple of changes that we made and then open it up for any comments. And I want to also thank folks who provided some input and pretty significant feedback on it. So I think it's close and we're in good shape. We did, at Andrea's good suggestion, add some introduction and partners to this to just, I think, for understood reasons. A couple pieces. We, of course, this is sort of a future state to some extent, since the data users are still, we don't have data use agreements that include the other public health agencies, just Denver Health. But we thought it was important to at least put that in here as our goal, since we also have in our work plan that we will have data use agreements in the next few months. So that was one new section of the CHORDS network, and just wanted to see if anyone had any concerns or questions or changes that they might make to that. Does that make sense to everybody? We also have not added the mental health centers as data partners yet. And I just wanted to, Jeanette, I didn't know if you had any thoughts on that. That might be a little longer process than updating data use agreements for bringing in the public health users. And I just, what do people feel? Is it important, do you think, that we put this, that we incorporate them sooner rather than later, even though we don't even know who might be our first?
Yeah, I think it's maybe a little preliminary, and it might be, you know, that's going to change based on what their requirements are in each center. So when you think about this, I just from my past experience with working with mental health centers, it may be a little bit different for each center. So just something to keep in mind. I mean, we could have a general kind of approach, obviously, but just keep in mind that those data use agreements may be tailored to other things. Okay. Does that make sense to the group?
Mm-hmm. Yep. Okay. I don't know that there were other significant changes. There were some wording changes in the different areas of deliverables and the guiding principles. But open it up. Anyone have any comments, observations, suggestions, things that they want to throw out for change? Any final edits for discussion? And anybody on the phone?
So I just have a kind of more general question. So is the governance committee going to set the timeline for the data committee, or is the data committee going to set the timeline for the data?
We're going to get to that.
Okay.
These are sort of all these, it's funny, as I'm putting the agenda together, I'm like, oh, which do we start with? Oh, but this is about that. Oh, but that goes into that one too. So actually we want to pivot over to the work groups because I think that that's where some of that conversation is going to start to happen. So if we feel okay with the way the charter works, I think this is our first opportunity for a little voting, but we're not going to do that in the room because we talked last time that people should have the option of confidential voting. So we will send out an electronic tool for folks to submit their vote. We'll also send out a final version. This is still marked as draft, and we want to give people a chance to take a look at it. So look for that in the next week or so, and hopefully we can get the vote and then adopt it and have our first successful product as a committee. All right. So the next piece we wanted to talk through is just a little bit about the work groups, and that I think connects to the data committee. I did make some copies for folks who are in the room, so I will hand these out. Folks on the phone, we're actually looking at the data work groups, the work groups that we had identified. I think that we had sent those out a couple of weeks ago where we had two work groups. One is the data model group and the other is the data exchange group. So first, I guess, Sarah, I might turn this over to you to just say more about the questions that you have and how we need to focus the work. What I've got in front of you all is just what we shared, as well as the folks who have volunteered to participate in these groups, including folks from Denver Health and University and Children's.
All right, so I would say that I think the kind of key things that we need to kind of outline within, I think, these groups is, so I think actually what you have here, the deliverables, is really good. I think a couple things to add to that is not just what defining the data model and data standards, but also more information around the kind of how this is going to be accomplished and how the definitions of the data standards. So, because there's two kinds of definitions. So there's the general network-wide definition. So we all have to fit that definition. So we have to first come to agreement on what that definition is, and luckily we can mostly rely on what's defined in the VDW, but as we found before, there is some ambiguity there that we need to define a little bit further. And then we also need to define that within our own data and determine how we're going to map our data to that whatever those standards are that we decide upon. And so we might need to break this down into what's kind of expected for kind of network level, which I think is the work group.
Yeah.
And then what is dependent upon that, which is the local work as well. And so I think we need to have timelines set forth for both of those so that we can make sure that we actually have the standards before we're expecting people to do them, because I've been involved with lots of projects where they tell us, oh yeah, you need to have all this work done. And we're like, well, can you give us a data dictionary or you need? And sometimes there's just not enough time between the general deliverables and the time for us to actually do the technical work.
Totally agree. We were actually just talking about this morning to kind of build upon that. Additionally, how do we identify and capture the information about the decisions that were made at the site? Like, okay, if there's an encounter type variable and it has a value of AV for ambulatory visit. So how do we capture, and what's the right amount of information that we need to understand about each participating CHORDS site about what an ambulatory visit means?
And it's because it's sort of a two-step process that there are some standards already available around definitions for the network, but then the committee will also need to digest and understand some of these site-specific issues in order to make sure that the network definition standards are feasible, practical, and implementable.
Mm-hmm. So definitely, and that the data that comes back is usable. A really good example is if we're going to start working on how we monitor diabetes control at the census tract level or at the county level, and I send a query out and I have 2 data contributing sites and CHORDS who are going to provide data, but one site gets lab results on paper and not in a structured way. We need to make sure that, one, PopMedNet provides information back that, there were no HbA1c results, but that's not because those tests weren't run, but just because that data is not available, and that doesn't mean like this site's not doing screening, and that we understand that the people who get the data back know how to appropriately use the information.
So what's the right order of operations for that? You're a data user and a technical person, and you're a technical person and a data contributor. I mean, what's the, you're both on the committee.
Yeah.
I mean, how would you see, okay, so over the next 4 weeks, what is feasible in terms of the decisions and the work that can get made at the committee level and moving down to the site?
So I would say, for one, I think we need to first prioritize what the data domains are, and I think we need to tackle one domain at a time. And then I would say, once we actually know what those data domains are and we have them prioritized in order, I think we'll have a better idea of what our timeline would be for working on defining some of this. Also, we first, I think, would look at what is in the BDW model and then determine how much clarity we need in that. And then after we've established those standards, I think that's when it would go to the sites. The sites would determine how they do that locally, and then they would feed back to us if they have any questions on anything. So I think, just following on what Emily said, a really good example with outpatient or ambulatory encounters is that, so for instance, we have one project where they want us to include every kind of encounter, whether it's in person or not. And so what happens, though, is that if your only choices are ED, inpatient, and outpatient, then that means anything that is a non-physical encounter becomes outpatient. The other two really don't make sense. But what happened with that is that when we started actually running queries on the data, we found that the numbers were way bigger, about 5 times as big as what we were expecting, and it didn't make sense to the end users because they were expecting much different numbers. And then they also found that, oh, well, all these visits don't have any insurance associated with them. It's like, well, because we don't charge for a telephone encounter, but we do charge for a regular ambulatory visit. And so I think identifying specifically what it is that we want to do. So what is our goal with this data, right? So that we can better define what those are. And then I know that at least for the VMI project that we did previously, we actually added visit subtypes for ambulatory because of the fact that it was such a huge category. And for us, at least, we have ambulatory surgery, but we have ambulatory, clinic visits, and then we also have these kind of non-visits. And then now there's lots of telemedicine visits as well, which they're not in person, but they are really considered a visit where they're interacting with a clinician. So.
I first want to stop. It sounds like maybe some people have joined us on the phone. Is there anyone who did not introduce themselves that is with us?
No.
Okay, great. Anybody on the phone want to weigh in? Are you hearing things okay? Okay.
Yep, this is Allison. Sounds good.
Okay. So it sounds like this work group deliverable one, sort of the data model and the data standards, is really the first step, and the other things that are associated with it kind of flow from these first pieces that you all just talked about, correct? And then in terms of who has volunteered to participate, do we need some other perspectives on this group right now? I'm thinking specifically around, do we need an additional data user to weigh in? I don't know, Emily, I'm looking at you because you straddle the line, and you probably will have a feel for what these discussions will be like for the first few. I mean, Kaiser's a data user though too. I mean, you all have, you use in a kind of in a similar way to Denver Health, but so I suppose David could also kind of be in that. I don't know. What do you think?
Quite candidly, I think we have like a mountain of initial work to get done that we really need to get ourselves organized before we would go to a data user. I would sort of be afraid to bring on an LPHA person and force them to suffer through that with us. Because we just need to write a lot down. You know, some of the things that we just discussed are one of many, many examples. So I think this person should be added to the group.
Greg, you're like on everything. You're just gonna
all groups.
Get it done.
But it's great to know that Sarah has that perspective, because the truth is, like, I've worked a lot on how you develop the ETL to get the data in, but I have really never, I mean, we have sort of tape and glued any sort of monitoring or documentation system together, and having participated in the PCORI studies, and I'm sure David will have some suggestions from BDW about the way all those details are documented and the level of detail.
I was just thinking, I know the Healthcare Systems Research Network, they have a place on their website to document these anomalies in the BDW. So when you embark on a research study in a certain area, you know why the numbers are not what you would expect.
Right.
So I guess my question is, CHI going to host a website for CHORDS?
Yes, that is the plan.
And we're actually kind of thinking of, so, and David raised this, that there might be a need for some different space where some of what you're talking about is available. He threw out like a GitHub or a wiki or something, and I know universities thinking about that. So this is...
We have a GitHub at the university for like .NET code, and so we could, you know, talk about great stuff on there. And then I think the thought is also that the university would host kind of a research side. And so I have to say, I haven't been on this website that I just mentioned in a little while, but I do remember that there was a logon and password to get to that information. And I think it was, I don't know how proprietary this group is, but that was a kind of a big governance issue that I guess if there were problems with your data, you sometimes didn't want that to get around unless you could explain it. And I think that was the point, that if the data aren't what you expect, you want a chance to explain why. So, for what that's worth.
So one thing that we found with some other projects is that there's really two different levels of documentation. So there's your technical documentation, which is what we decide, how we do, make our decisions, how we do our ETL. And so, and that's something that I think lends really well to a GitHub type atmosphere, and that you can do behind a password so that nobody else can access it. Also with the fact that, maybe all of us, or most of us are using Epic. I don't know about the mental health folks. Okay, so look, you guys will use something else. But with Epic, their code is, or their tables and table names and columns are actually considered proprietary. And so we actually cannot make that public. We can share it within the group, but we can't make that public. And so if we want to keep track of everyone's ETL code, and the nice thing about that is we can actually look at each other's code when we're using the same system. We can borrow from it or see how other people did it. I know we've already shared ours with you.
Thank you.
And we do that with our other projects. So I think that the GitHub might be a really good place for that technical documentation. But I think that we also need to think about end-user documentation, which I think is going to be much more simplistic, and it's going to be more in the style of like a data dictionary, where it says what the variable is, and it gives a really clear definition of that. And then one thing that you might add to that, which I've done in some projects but not others, is more of a provenance, which is getting to what Emily was talking about, which is really understanding what that data means per site. So this site, you know,
I'm sorry, more of a
data provenance.
Data provenance.
Yeah.
Like
New.
Only our primary care clinics screen for tobacco use. Right. Our specialty care clinics don't screen, so don't look for tobacco values on specialty care visits. So it's what's happening in the healthcare delivery model that's represented.
Okay.
So it basically gives an understanding, a very high-level understanding of the data to the end user before they actually use it, or if it's implementation and go right in, they can look it up afterwards and say, oh, that's why I'm getting this result.
So you already have these documents?
Maybe. No.
No? Okay.
I mean, we have some.
We both have these types of documents from other projects.
Yeah. Just not
so will David.
Right. Yeah. We'll want to look at all of those to see what we can beg, borrow, steal, revise.
We can steal a lot.
Two question. Well, one question. How? I mean, this will be helpful for our current users and our current partners, but I'm also thinking future state and expansion and who else will be joining. And I don't really know what my question is in there yet, but what do we need to be thinking about in developing these standards, these definitions? I'm throwing out terms that when we're thinking about folks who may not, who don't have EPIC or who are using a very different system.
So I'm already thinking on my to-do list is to find out how proprietary codes are in Avatar, because there is the capacity for virtual data warehouse in that.
Right.
And not all the mental health centers are on the same medical records, and they're all in some kind of transition to a new medical record or health record, and with the exception of MHCD, who did their conversion last year to Avatar. Jefferson Center goes live this fall. It sounds like Aurora Mental Health is considering changing, and then Mental Health Partners in Boulder, I think, is using, gosh, I'm trying to remember, NextGen. So they have different records. The majority of mental health centers are in Avatar, so we'll need to figure out what that's like, for lack of specificity. And then I think the other thing where I could be useful is circling back to Emhart through the mental health research, or the healthcare systems research network, because the fields that Kaiser uses in their virtual data warehouse are very medically based, and I know that the mental health centers will probably want more behavioral based tables down the road. And as the user, bringing somebody on who's a data user when kind of things are organized from the behavioral health side, I think will be very helpful in working with these other two groups here. But obviously that has to coalesce first, and then we can bring somebody on. And then the other thing I thought about was, has there been any attempt to outreach substance abuse? Is that something we want to think about? Because that's part of behavioral health. But that gets into the whole 42 CFR Part 2 issues. But I was just wondering if there was any discussion of that up front. Because there's a Arapaho House who's doing, they may or may not want to have a role down the road. That may be too expansive for this project, but I just wanted to throw that idea out there.
I think everyone's really interested in that, but I feel like that's a long way off.
I know. I feel like we're all a little scared about how to actually
kind of like phase 3 or 4.
Yeah.
Okay. Yes,
but it's in the mix for sure.
And if that's, at some point we want to go there and there's funding or the availability to do that, I'm glad to have those discussions at Arapaho House.
They would be the likely first.
Okay. Yes, especially the Denver metro area.
Okay. Anything else to talk about specific to the data model group?
I will say we did just talk about a lot of things that the data exchange group should probably.
Well, that was my next, and oddly enough, it's the same people on both groups. So, shocker.
This is Jessica. I just wanted to raise the issue that we're also contemplating, at least we've talked a little bit about this in hallway conversations, switching the data model completely to something like OMOP. So just wanted to remind people of that, which I think is a little different than what we've been talking about, but probably is the same group. Does that make sense?
It does make sense. Would someone, either Jessica, you, or someone in the room, fill all of us in on the implications of switching the data model? And you just say, Emily, so I don't want to put you on the spot. Is there anyone else who?
So you just basically would have to modify your ETL is the biggest work piece, but we'd have to remap everything. So we have both.
You as a site.
What's that?
You as a site, as a data.
Yeah, as a site, yeah. So we actually have both up and running at ours because we use OMOP for our PCORI, which is PedsNet. And I don't know, I don't know enough about VDW to know the pluses and minuses of one versus the other. I only know of what we have, and we don't have that much for VDW. I do think OMOP is a little bit more robust, right?
I can say a little bit about it. I don't know very much about OMOP, and others undoubtedly know more. But one aspect of OMOP that isn't present in the VDW is that it's tied to sort of a hierarchy of vocabulary. So, for example, if you want to ask about non-steroidal anti-inflammatory drugs, you don't have to name every single one of them. You can just say, tell me about the people who take NSAIDs, and the data model allows that to be, splayed out into all of the different NSAIDs, and so it's quite. And it also there's a group called Odyssey that has a bunch of tools that make use of OMOP. So there might be compelling reasons to make that switch. I know that Lisa Schilling is contemplating it for other work that she's now got in the VD. No, I may be confusing things. Let me take that back. Anyway, there may be some reasons to make that switch, but it's also true that there are increasingly some tools out there that would take the VDW information and transform it into OMOP. So how much work it would be for the sites, I'm not really sure. Anyway, I just, that's an issue. It's a pretty big issue. It's hanging out there, and I think we just want to make sure that it gets a place to live, and I think this is the right place.
Okay. Are the data standards and definitions the same regardless of the data model?
No.
No. Okay. So.
And actually, OMOP has a lot more standard terminologies, I believe, than VDW. Mm-hmm. So that is one advantage that you get by using OMOP.
Mm-hmm. So does this group need to first just make that decision?
I think that the work group, the data model work group, would need to prepare, I think, some information for the group to make a decision. So there's also several things to consider. There is the OMOP or VDW scenario, which is where we switch and abandon one or the other. And then there's also the option where PopMedNet can tolerate either. And each has its own complex set of issues. There are a lot of convenient things about OMOP. I don't know a lot about the data model either, but I've heard that there are more groupers, like Jessica's example. I've also heard that there are claims in OMOP, which is a glaring issue with VDW that a lot of researchers have a problem with, is that there's no claims. You can't do cost analysis.
But what does that mean for public? Well, I guess.
Right, so for public health, not a lot of implications. They haven't really been historically interested in that. I suspect a group like CHI might be interested in some access to some claims.
Or a group like Tri-County Health.
Or a group like Tri-County Health Department, absolutely.
It also might be hard to get claims data. Yeah, it's expensive.
Yeah.
Right.
This is Jessica again. This is not a short-term decision, and we shouldn't hold things up for it, but it just needs a place to be explored, and I think this is the right group for that. I know there's I remembered what Lisa was contemplating changing. It's in the P-Scanner project that she's working on, and there's actually a meeting in September sometime where a group of people are going to get together and discuss, and this is in Washington or something, the VDW versus OMOP question, and somebody from Lisa's group will be going, so that we can bring whatever is learned there back to this group.
Mm-hmm. So thank you, Jessica, for that. So I'm going to keep that. We'll keep that as an issue for the data model group, not the data.
I think that the data model and data exchange group should meet back to back in location.
I think that would be good. What should we talk about with the data exchange group that's not there? And can the data model definition standards happen at the same time as these other?
Yeah.
Okay. Mm-hmm. So what else?
So I think in my mind the data exchange group is really focused on how the client works and what data, how PopMedNet,
thank you,
works. What when we say there's an adapter that will query depression prevalence, what fields it uses, what's the logic. I remember hearing Jessica tell a story about Michael Kahn, who's not here today, who apparently demonstrated that there's 15 ways to define a diabetes case. Yeah. So you think it's really straightforward, what's the numerator and denominator, but it's not. And there's a lot of different ways to do that. And there's a lot of approaches to addressing many of the different limitations. You know, the folks in Massachusetts and New York who used a sort of similar approach just used ambulatory care because it's a way to like reduce duplicates. So that's what that group needs to work on, is making recommendations for how all of the, we're calling them adapters, right? Is that the right term now?
Yeah.
They're not plugins anymore. They are adapters, which is the structured queries. And so that group really needs to flesh out, these are all the issues we know there are in the data. Some we can fix, some we can't fix. These are the ways an adapter can function that will minimize these issues. And this is the information that's provided to the person who initiates the query at Tri-County Health Department that tells them what they need to know so they can use the data appropriately.
So, okay, all that. Prioritize that for me. What's the first, in the next 4 weeks, what's the first thing that has to happen in that?
Maybe writing the use cases?
Yeah, I'm trying to think.
Should we and put that in the context of requirements for data exchange, technical requirements for the central hub, and technical requirements for the data partner node?
Well, a lot of that's written. A lot of that exists.
This group is
just like on the other side, a lot of number 1 exists.
Okay.
Just in places, and it needs to be pulled together. But the requirements for PopMedNet are, you know, kind of scattered about, and that's probably the first thing in terms of basic requirements for aggregate and record level returns.
Okay.
And we have that use cases document.
Yeah. We have use cases documents. We have other documentation. I'm wondering if a good place to start would just be pulling in our documentation and seeing what we do have down. And when we talk about requirements for data exchange, are we talking about the user side, or are we talking about the data contributor side?
I think it's both.
Okay.
Actually, I think this group was really first going to stay focused on the data contributor side because the user's a little bigger, and I think there was some discussion about if we're clear on the technical pieces first. But it's shortly to come that it will pivot.
Gotcha. Okay.
I don't know what that means.
It seems like it might be sort of hard to do one without the other, because what the, I mean, I guess if the data contributor is, I receive queries, I get an email notification, I can review the query, this is the information I can see about it, I can say yes or no, I can see the results, I can release the results.
Yeah. And I mean, does this also include like one step before that, which is like I have installed PopMedNet, my CMR client?
I don't think it includes getting the data into VDW, but I do think it includes I requested a password, I requested a username, I installed it, I tested it.
Right. Okay. Okay.
So I think there's 2 issues that are related to data exchange, but I'm not sure that it's the data exchange group that actually tackled them.
Yep.
And so one of them is turnaround time expectations. So when somebody submits a query, how long it takes for us to either approve or deny.
Right. I have a list of these.
And then the other one is establishing an SOP for the regulatory requirements around releasing the data through the client.
Say that again, please.
The establishing like a SOP for regulatory requirements around releasing the data. So if somebody just wants counts, for instance, if it's less than 10, or sometimes people say less than or equal to 6, I think we actually use less than or equal to 6 as our threshold at children's, then that is considered identifiable data, right? And so just giving counts of that has some regulatory requirement around it. And then also, if somebody wants a limited data set, there's regulatory requirements around that. And so we need to make sure that the people who are approving those queries are aware of what those guidelines are, so that they're not approving something without the proper documentation, and then also developing a process around that. And so I think that's more of a, I would say, like regulatory governance committee that would do that. I don't remember if we have one of those.
And then what pieces of that should be built into the client? Like, should PopMedNet send you a warning? It's like, warning, less than, this return less than 10 records.
Right, yeah.
Is that possible? Does it do it now?
It does not do it now, I don't think.
Is that, okay.
in terms of QA queries, it doesn't return information for less than 6.
Oh, great.
So it just like drops those.
Okay. But then would it send a note back to the person who initiated the query and said there weren't enough results to answer your question?
No, and Bryant and I ran into that where we were comparing two where it was kind of like a larger aggregate count, and then it like broke it down into categories. We were like, why don't these numbers match up? And it was like, because one group was 6, and so it just dropped those. So I think we need to think about where that control lives and can we program in warning.
So actually I was going to ask regarding that. So instead of having it drop it, can you have it programmed so that it'll just say like not returnable or
I think so.
Still too small?
And it might not be a warning in that case, but it would be like in the table.
Yeah, I think that would be better. That way you don't. That way you know that yes, it's there. The only thing though is that if you have a table before it gets that small, and then you have a table after it, and you know what that final number is, you can kind of subtract and figure it out to some extent.
So to your point about prioritization, I think overall PopMedNet specific data user and data contributor partner. Are we using partner? I think partner's in the governance charter. Remember? Okay.
It will need to be the same.
Right. I think it's partner.
Okay.
I think identifying and writing down those user stories and the requirements that are associated with them is like, as a user, I need to know if the query returns less than 6 results and have the option to decline it or have it happen automatically.
As a contributor.
As a contributor, yes.
So I wonder if we can start this discussion on that side of the house.
Yeah.
And since the folks in this group will know, I mean, you've already identified some of these, and we can just make a list. And I don't know, what do people think? I mean, to the extent that the technology can resolve the issue, it won't return a query if there are less than 6 records, maybe all the time. That we have that the technology can address the issue before. If it doesn't, then we need to set up a process for addressing it. Does that seem like a reasonable?
Yeah.
And so the group can think through those, and since the folks will also know whether the technology can address the issue and what the limitations of it might be, it can also make some recommendations about here's how I think this can work, or here's where I don't know that it can, and so it needs to go to a different group. I agree. I think there's some pieces there that would have to be hashed out.
This might even need to start in more of a regulatory group that defines what those are, and then the technology group can determine how we can incorporate those in. And then if we can't incorporate it in, then it might go back to the regulatory group to establish a workflow and standard operating procedure for how we handle those. So I'm just thinking, because I know some of us on this group really know well exactly what those requirements are. Some people on this list have no clue what those are. And then there's probably people who know more than some of the people in this group.
And I think you have to keep in mind that data managers, they sometimes change
Right.
institutions. So I always like question myself when I speak out loud in this group, but I'll try. So, but I think for Sentinel queries, we participate in the FDA Sentinel network. It's very clearly spelled out. This query is for this particular Sentinel activity. It was approved on this day, because it's also public health surveillance, which is why I bring it up.
Yep.
It should actually, they even have charge information. It should be charged, your time on this should be charged to this project.
Oh.
And results should be returned to X person. So it's very spelled out and structured, which seems to really help.
And where does that come through? Does that come through with the request? Or?
Yeah, it comes through email.
Okay.
Request. So you just kind of create your email to group, and we ask our investigators sometimes to be copied on those too, so they could review results if the data manager thinks that there's any issues with the results. So, and that seems to help a lot. And I think that does get a little bit to your point.
So maybe that's a model for us to do some digging into to see how they got to that place where they know that automatically.
I'll see what
I was actually going to ask you, Andrea, before you spoke up, if you had any input on this as our expert here. Okay.
But I do appreciate Sarah's point, which is it might not be a good idea to have the technology folks trying to just out of the gate think of all the problems that could happen and like build define the widget that will make sure those don't happen.
Not alone, but I think
Not alone,
there is
yeah.
some value in having you all think through that.
Sure.
As a group.
Right.
And again, with David also not, I mean, being part of this, that's something he's thought through. So.
Right.
Okay.
But to start really with like the list of regulatory issues the technology should consider reconciling and the things that it can do. So just an important thing for you to think about is if we built a thing into the client that said if there's less than 5 records, it will not return the results. That could be a huge problem for the research group. If it just did that automatically and we didn't have a way to have it just do that for surveillance and not for, and so the way it's implemented could have a ton of ramifications like for other things. So making the decision about what the technology will do and what is an email that's, I mean, something as simple as whether or not the technology strips out the site identifiers.
Right.
Well, what if we ever needed them again, or what if transitions of care between sites became a surveillance topic, and those are like gone, and we can't get them back?
And some of that stuff we won't be able to answer.
Right. Right. Absolutely.
But we will in 6 months or 12 months.
Right.
What current? You mentioned that there's current documentation, and because you've used it, is there just to think through what you've already relied upon when making these decisions?
There's a lot of documentation about the data model, but regarding these data exchange things, I don't know. And what exists, some parts of what's available for research are immediately applicable, and we could just copy it over.
Right.
But some things about some of the surveillance, like kind of nuances, I don't know if that's written down anywhere.
Monitoring.
Monitoring. I'm sorry, monitoring.
Okay. Okay. I'm going to pause. Folks on the phone, sorry, we've been sort of bouncing around the room here. Anybody want to weigh in or share anything? Jessica, I know we're going to lose you at 10 o'clock. Do you want to weigh in, or is there any, what else would you like to add to this discussion?
Well, I'd just say that because we write the queries, I think we can tailor them accordingly. So, for example, I would think we would be able to write something where the parameterized queries that we're offering to local public health departments do whatever level of obfuscation we want, because actually that's another technique. But anyway, and then the ones that we write for researchers could not do that. So I'm not sure that, well, basic message is that because we write the queries, we have a lot of control over how this works. Okay. But I agree that it's, anytime that you ask somebody to anticipate every way that something can go wrong, you can be sure they're going to miss something. And so then if the users think, oh, we don't have to worry about this because we know it's been automated to take care of everything that could go wrong, you miss an opportunity to find errors. So I think you never can completely take the human being out of this.
And just along with what Jessica was just saying about us writing the queries, I think that's a question that Bryant brings up with me a lot, is when he thinks about governance, he thinks about kind of a central, are we using a central model, which means that we always write the queries as CHORDS staff, or do we let researchers or investigators from public health write their own queries or submit a different query? And so maybe that's another decision for the data exchange group to settle on, is how centralized are we in submitting queries.
And I think that also depends on how available the staff is and how big of a workload it's
yeah,
going to be
absolutely.
too.
Mm-hmm. And when we start thinking about sort of the end user, it might be helpful. I know we've talked about Adam Anderson from Tri-County being helpful just because he's like such a smart guy and knows a lot about this and can probably help think through some of those problems. So I think as we get ourselves together, once we've had some initial meetings to kind of get some things down on paper, his perspective could be super, super valuable. I know last week I sent an email to Robbie and said, Robbie, is a person who's going to who straddles both sides of this, what questions do you need to know as a local public health department about how to use PopMedNet? And he just like fired off 10 questions that were great, and we're going to answer them all.
Who's Robbie?
Robbie is works at Denver Public Health, and he's the person who installs PopMedNet, receives the queries, And so he's both a data contributor and a data user.
Okay. Great. Okay. So next steps for the work groups. I think it's feasible in the next 3 weeks to find some time for everybody to sit down and hash through some of this stuff. I mean, I know we'll send something out to get that scheduled, but and last call, anyone who has not signed up or been volunteered for this group want to participate? All right.
Jessica, your name is not on the list, this list. Are you interested?
She's gone for her.
Oh.
It's a 10 o'clock.
Oh, okay.
I can ask.
Okay.
No, I'm still here. I'm still here, but my computer died and I was rebooting. So which committee are we talking about here?
The data model, data exchange co-group that will meet back to back.
Oh, okay. So it'll be both of them. Yeah, I think for the time being, sure, I'll be on it.
Okay, cool. Thank you.
That's what we can.
Would you want Bryant to attend?
I think it's possible.
Okay.
Yep. And so think about where we might want to hold that meeting. I know that there's sort of a critical mass of people at the university and at Children's out in that direction. And it would be delightful, work group, if we can get some of these first pieces, like what are the domains we're going to prioritize, what are some of our existing documents that we already have, if we could have that stuff pulled together before our next meeting in September. And if there are questions that I will participate, not be helpful, but I will be there, can identify that need to come back to this group. Sure. For some additional conversation. Sure. Okay. All right, work groups, moving on. So we have two other things to talk about, and I'll sort of take a pulse of the group. One is thinking a little bit more about data sharing and data use agreement. The other is looking at this a table of contents that we've pulled together that we're proposing is sort of the shell of the governance plan, the Big Hairy governance plan. I think on the data use agreement and data sharing side, we probably will need to talk through the different types of data products and the users and how we feel about how we, what documents need to be in place to govern the exchange of those. On the table of contents side, a little bit about like, where do we want to talk about, where do we put in here some of the pieces around change and when we're making a change to the data model. Do we have the right committees and councils in place to be thinking through who's writing the queries and where would that sort of question live? So a little bit in the, like, what might be some of the guts under this, knowing that you all won't have to, it's hard to know in the absence of seeing it. What do we want to do? Table of contents? Data sharing. Table of contents? Data sharing. Table of contents. I was thinking maybe table of contents. For folks on the phone, this was handed out, or this was included in the email that we sent out earlier. It's a 2-page table of contents for the governance plan. And so let me pull up.
Excellent, thank you. This is Susan Moore. I apologize, I have to drop early for another standing meeting that I'm in the process of meeting, but I'll see you all again next month.
Not a problem. Thanks for joining us, Susan.
Thank you.
Okay. So I'll just walk through at a high level, and again, I want to give a little shout out to Andrea and the folks at Portal who have provided some great tools that we are using really as a template for this. So the introduction is hopefully fairly straightforward, and I think we actually wrote some of that already in the governance charter. Check. The next piece is around organizational structure. There are a couple of pieces that a smaller group has sort of talked about that the governing board is really sort of the decider, if you will, but that there might be a need for a smaller group that we're calling the executive committee, although we can call it sort of whatever, that is in a place to make some decisions a bit sooner. The governance plan would identify how and outline how they make those decisions and how they would have to consult with various members of the governing board to ensure if it needs to be a quick time decision, or just kind of, I think Jessica said, like just to make sure that the lights are on at CHORDS, that there's this smaller group that is kind of doing some of the day-to-day pieces. We toyed with calling that an operations committee. We called it executive committee. Sounds informal. And then identifying the participants, we're calling them partners and users. As we talked about in the first piece and in our charter, we're going to try to align as much governance around public health and research as we can, and only where we feel like we need to be specific with both, we're going to break that off, or separate that. So this is an example where we felt like we needed to be explicit around who these different types of data users are. And one of the things that we actually have in the data sharing matrix and a little further down is this idea of like not all researchers may be created equally. What if a data partner is also interested in being a researcher, and so affiliated researcher versus someone from another state who is interested in tapping the information for research? I suppose we could think about that same question from a public health perspective too. Never thought about that anyone other than a Colorado public health agency would be using this for purposes of public health surveillance, but just thought about that.
Well, I think one important thing to consider along those same lines is a public health student or a public health school or a public health agency like CHI that's not trying to do research but wants local health data that we would consider surveillance.
An example would be Denver Environmental Health.
So they would technically, I think we would consider them a local public health agency.
We would. Okay.
They are actually the official city public health agency, but another group would be like Kaiser Community Benefits or Live Well.
So question, so would we, since again this is sort of that like in a 2-3 year phase, not in a 1 year phase, is it worth identifying that and talking about that now, knowing that our data use agreements are only going to be with public health agencies, not anybody community-based? Right.
I think it's worth talking about it because those are the people who are filling up our inboxes.
Oh, really?
Yeah, I mean, a big push for CHORDS is based on like incessant inquiries from the Mayor's Children's Cabinet and from Live Well, and so that's a reason that I think this was funded. Even things like foundations.
Yeah.
And so, is the recommendation that they are going to go to the local public health department and ask them to submit the query, clean the results, do the analysis, and send the results back?
And I'm really glad you actually say that because that's part of the work that CHF wants us to think through also.
I know they want this data, you know?
Yeah, the grant.
And then do they go to all of the health departments for all of the, that represent all of the census tracts that they are doing work in, or are they able to ask Denver to query the 5-county area, or do they just get a login?
Do we separate these, all of these, I mean, do we have public health agencies as a data user, and then we have researchers, and then we have others? Like, are we trying to put too much in the space of public health, even though the data use is probably similar to a public health use case?
I think we could add number 3 under, or maybe not participants, or like interested audiences, interested partners, interested data consumers. I'm not sure what those words are.
Or data users.
Not to get data users too into the weeds, but if you are using public health students or any students, graduate students from anywhere, I think we need to think carefully about how they're supervised and have some additional documents.
Oh, sure.
And I'm saying that up front because of some of the requests I've gotten at my agency.
Right, that are off the wall.
Yeah.
Absolutely. So maybe that's like just a placeholder, and we put like, we know public health students would be interested in this. We'll deal with this later in 4 years. But I think like professors at the School of Public Health, that's a really valid and currently interested prospective data consumer.
And they would not necessarily be looking at it for research.
Oh, yeah, definitely not.
Yeah, okay. That's different.
So like Tessa in the congenital heart disease study, although it sounds very researchy, her use case, she really feels like, and it's funded as a surveillance activity. And I mean, the line between the two is essentially going away.
Jen, for the BMI project, how do you categorize? Do you have categories of data users?
No.
Okay.
We don't. I mean, we have a long list of different types, and I'm thinking that that would be informative for this group.
That'd be great.
For you know, kind of coming up with our categories.
Because I remember one thing we were surprised to see was a consulting firm.
Yep.
A private for-profit consulting firm requested the BMI data because they do transportation consulting.
Yeah, they were looking at the impact of improving communities, and that would be one indicator they would track.
With shot at obesity rates.
So another thought, what about commercial health plans?
Right.
Especially in the light of the rave rebate.
And then the challenge also becomes, do you get special treatment like if you're contributing your data? Yeah. So Kaiser, Colorado contributes all their data. So do they get special permissions to use this network? Can payers who aren't contributing data yet query this data?
Yeah, just something for us to be aware of.
Yeah, again, I think it's best to identify all of it, knowing that we'll chew off some of it and just keep working on it.
Well, that's going to happen like this year, like the next year.
Yes. Additionally, the hospitals that are doing community health needs assessments, they will want this, including non-contributing hospitals. So, like SCL would love to have this data. They don't want to give us any, but they would like to have it. So
we've had requests or interest from like Colorado Access.
Sure. Oh, okay.
Oh yeah.
When they got wind of what it is, I mean, they aren't completely understanding how it would help them, but they're interested in learning more.
And I think it's likely there's so many nuances and different like scenarios that that's something that we would just write, just like the BMI project does. A committee of very smart people will review all these requests and say yes or no and figure out how.
Because you're going to have conflicts of interest there. That's
yeah.
It's going to be ugly. So we really need to think about this sooner than later.
Right. And then do they pay?
Yeah.
If you pay, do you play?
Jen, you said that you've got you might have some documentation from the BMI project, even just how you categorize these folks.
Yeah.
Okay.
Yeah.
Yeah.
Has anyone in BMI ever offered to pay for the data? They've never tried to buy it from you?
I don't think so. Maybe. I mean, I don't think so. I can ask Leanne. She monitors all of our requests, but I don't think anyone's. I mean, because we don't. It doesn't come up because we don't ask for any payment. So I don't think they'd offer to pay if we.
Did you have a thought?
That's a good sustainability issue.
Yeah, it is.
Well, yeah, and actually we've been asked by various places, and actually I believe even when we were looking at the mini Sentinel project, they even asked us what our charge would be to provide our data, just as like the cost of the data itself, not the work that goes into it. And so I do think that that's something that at least we are considering at Children's eventually having a cost structure for that, to say you have to pay for the data, not just for the work, but for the data itself, because the data is valuable. And then one other thing I was just thinking about as we were talking is that I think we definitely need a really good sounding board to review all of these, because depending on who's requesting and who the data partner is, the feeling of giving that data might be different. So another payer wanting data broken down by payer might be something that Kaiser doesn't like. I'm pretty sure. But, I mean, Children's, we were like, oh, sure, you can see that. Or, you know, let's say Rocky Mountain Children's Hospital says, oh, we want to look at all your data by hospital, and then we might not like that. So I think that that is something that we definitely need a really good board who has all the right people involved. And that actually might even need to, not necessarily on the board, but at least have an avenue for reaching out to the appropriate people at those sites. So for instance, certain things I don't think I could make a decision about, and I don't think Michael could make a decision either, and that we really need to go and talk to our privacy officer or our research compliant officer and stuff like that. So
it would be the same for us. We would have to reach out and figure that out.
Again, I think important to be thinking about. We probably won't decide, but again, these are some of the pieces like this in this commercial space. It almost feels like that might take a few people around the table sort of thinking about how do we actually want to move into that space, or do we, or can we?
Well, even with Medicaid, I mean, that's going to be highly contested, and people are going to want data for their RFPs now. So we really should be very careful about that.
And right right now, again, the only change in the data use agreement we're proposing is for public health, which would not include any of that. I mean, it would potentially have payer attached to it, but
yeah. Right, and the challenge is that public health is the vehicle that provides data currently for, I mean, I pull data for our, and so the moment that
for your own, for Denver Health,
for other people too. Like the Stapleton Foundation would call us and say, we're writing an RFP. Can we?
And you as Denver Health.
And we would pull any Denver data that we have for them. So that is an existing process that...
what governs that decision?
Who has my email address?
So nothing.
Nothing. I mean, like we would never share anything identifiable, but it's, right. I mean, it's a pretty tough situation because it's usually like is about leveraging relationships.
Well, and I guess it raises the question, if it's information that you've already put out in the public domain, you've put the map out in a city council publication. If someone calls and asks for a different file, you might just have this JPEG as opposed to having the PDF map in it. Is there a decision to be made, or is it like it's already out there? Sure.
And then, like, okay, if they're asking for something a little different, I've got a program written, but I've never actually showed the data before, but, I mean, these are people we work with all the time, and they're going to write me into this grant. So, like, sure. And we know them. We totally trust them. And so that's not official. So I agree with Jeanette. It's important to be cautious about what's available for use. Like, we should open the dam very slowly.
And with the BMI project, we've kind of established standard products, and we don't really need to go back to the committee to release those. And then when we get special requests, we bring them all, bring everybody together.
That's something that's not in the data sharing matrix, but it was in an earlier version. And just for ease of data contributors, would we want to think about having a set of standard data tables that or something, set of products that are updated every quarter, every 6 months, that just happen and they're publicly available and they're posted on the CHORDS website, and everybody knows what's in there and everyone agrees to doing those, which could minimize some of these other pieces or some of these other asks.
I think that's important too for when people are looking to see if this is a useful data source for them, so they can actually see something about the data. So they can at least see how many patients or how many visits or what kind of, the geography, what kind of diagnoses are involved or what kind of procedures. I think that's really helpful for people because, I mean, otherwise I think people are almost just taking a guess when they put in the request to say, I think you guys might have the data that I want. I'll put in the request, see if you approve it, and then I'll find out. I think that at least gives them kind of the upfront view of whether it does or not.
Is it? Oh, sorry.
I was just going to add, that just triggered something for me. It's not only providing them the data, but walking them through the data, which is so important. That's also a time-consuming and something that you want to consider associated with that.
But I think your idea is good, and we should absolutely have census tract level estimates of childhood and adult obesity as like an automated thing that happens. It should run, we should generate a protected Excel sheet that is locked and only shows, the percent and the N of the denominator, and it should be posted to a website because that is the email that we get over and over and over again.
Sarah, putting you on the spot here, as a contributor, is that something that, how would you feel about that?
Well, I think it depends on what exactly is included in it, but for the most part, I think that's fine. And I mean, so, for instance, when we started PedsNet, one of the first things we did is we actually published an article on PedsNet and what it was, and we included basically that high-level information that we have this many patients, this many visits, data spans, this time range. For that one, we didn't have the granularity at that time yet for the geography data, but we at least said the regions that our hospitals are pulling from. So I think that kind of information, we can all agree upon what we think is appropriate to just have always out there.
This is Allison from Tri-County Health Department. Can you hear me?
Yeah, you got the floor.
Okay, great. So I think that in my mind, one of the reasons that local public health agencies are considered data users, and one of our roles would be to kind of facilitate data access for community partners, not to act as a gatekeeper per se, but to be the ones who are a conduit to the data so that we can take responsibility for working with our community level data partners about what's in the data set, what can they get, that kind of thing, and then help explain the data. And maybe I'm not reading that correctly, but that's kind of what I was thinking one of the roles local public health would play in this project.
No, that you're actually right on that, Allison. Thank you for calling that out. Yeah, I think in the absence of having what these specific use cases look like, some things that might rise to the level of being more like research or market research for that matter, we're sort of lumping into this big space of public health, which is maybe not, or is not, maybe not, I'll say. But no, you raise a good point. That's, and Denver is serving that role de facto right now as the only source for this information. Right, and to what extent are you able to currently do that? In terms of really, you mentioned that these are folks who you have relationships with, you know what they're working on.
Analysis for them.
Okay.
We don't send them the data, we make a graph and send them a graph, or make a map and send them a map. But it's hard because the resource light thing to do is to just give them the data and say, like, enjoy. Yeah. And that is not going to be feasible for this. And so I'm glad that Allison spoke up. I think that's an important role that we could task local public health departments with, and something we can think about for the training that they'll need is, one, what things do we need to consider about the way we deliver and present the data that enable local public health to know enough to have a conversation with LiveWell without us on the phone. Right. But also what about, so what information do they need, and what information can help design like how the data is presented?
So this just dawned on me, this might be a space for CHI can actually be helpful from a content perspective. We get like 400 of these requests every year for information of all kinds. And right, we rarely just send someone a data table because it's not really the question they're looking to have answered. Sometimes it is, but usually it's another, there's this unarticulated, we call it the unarticulated need that they really are looking for. So, okay, great. The last thing, and I wanted to just check it back in on this concept of an executive committee to see if folks had any thoughts on if that's a good idea, number one. And then number two, maybe it's more, if there's anyone who shouldn't be part of the executive committee. I'm not going to say who should. I think we probably all agree. But there are certain groups that just, and those of you who are maybe participating in similar types of groups where you need to make decisions or where you're, is there a best practice? Is there something like, oh, if we have like less than 5 people, we can typically make it work? Or just anything along those lines? Anything on this side or group?
So kind of more like a steering committee?
Kind of, yeah.
So and some other projects where we have those, there's usually some requirement of what your title has to be to make it into what. Yep. But the biggest thing that I've found is that there needs to be either an even distribution of stakeholders, so, or I guess data contributors in this case, or there needs to be some way that the voting is adjusted for the fact that some parties will have a larger voice than others. And so we've done that before by having like a weighted vote where each person has such and such weight so that no site has more than weight than anybody else. Or we've done it where just one member is like a true voting member and decision maker, and when the rest are just there to help facilitate the conversation. Okay, that's helpful.
Hey, it's Kate Horley. I definitely think that the executive committee is a good idea. I think it makes you need a division that can be nimble in making decisions for sure, and getting your big group together and then having a lengthy conversation about decisions every time you need to buy pens is really complicated. And you know, I've never worked for a nonprofit that didn't have an executive committee as a subset of the board that was tasked with certain set of decisions. And I've seen it done in a variety of ways. Sometimes it's a member, it's the appropriate representative of an organization, or it's by role inside governing board or it's by stakeholder. And I've seen all three of those models work just fine. So I think it's going to just depend on how you want to slice and dice it, but I would definitely argue for 8 members or less, for sure.
Thanks, Kate. And Kate, do you want to just tell us who you are? Because, right, you were joining us a little late.
Yeah. Hi, I'm sorry. I'm Kate Horley. I'm with Coreo.
Thanks. Andrea?
I was just going to say that I think it's really important, especially, I'm just thinking about Jeanette's thorny issues that she brought up. I think it's important to delineate what the executive committee can decide on and what they more tee up for the rest of the group to vote on. I think that's really important. Because there'll be issues that individual data partners do not want anybody else speaking for them on, and I think we just need to be clear about that. Yeah.
And then I was just thinking of this thing that is happening in a committee that we're running at Denver Public Health where it's not just yay or nay, but there's like levels, I should call it, it's like a 5-finger vote, where if you like are a 1 or 2, you're like, I can't live with this. 3 is, I don't agree, but this can move forward. Or 4 or 5 is like, I'm totally unanimous and in favor of this, and anything below a 3, we talk about it more. So do we have to reach total consensus, or is it majority vote? And then how do we deal with when we don't agree, and things are able to move forward?
And that is a piece of the third part of the table of contents, which is actually just around decision making. I don't want to go to there yet, though, but yes, I like this idea of having different types of decision making for different parts of the organization, or different, yeah. The last piece I want to just think through a little bit on org structure, and that's where I was hoping we would spend most of our time, so it's not like we're going to be walking through all these other pieces, is around the advisory councils. And Rachel and I sort of worked through these a little bit to try to think through who we would want to have be part of those councils and how they could tackle both the data component, which is what we're thinking about from operations, and maybe this discussions that we've been having with the work groups, that potentially the work groups might evolve the folks who think through these technical data model stuff into this council. And then community engagement is sort of what we were thinking through around the public health activities and the community partnerships. And then clinical engagement, thinking a more broad term for research. What we've, yeah. So it seems, are we missing something right now? Knowing that this is all.
Can you remind me again about the kind of purpose of the advisory councils? I sort of don't remember this. Oh, it's new.
It's new.
Yeah. Okay.
Well, this isn't that new. Other groups do this, right?
This is pulled out of the portal. Yep, right, yeah. The portal table of contents.
Based on their,
yeah. And we, I had kind of taken that previously, and then also kind of brought in some of the previous CHORDS public health policies and principles and policies document that had been in draft form from earlier. And so this is kind of like
for 3 years.
Yeah, yeah, that one. So that's kind of okay where this comes from.
And so these groups might be where it's sort of, it's not just the folks up above, like the board, the participants, or the committees, but it might also include, like, you mentioned the Stapleton Foundation. You've talked about Live Well a lot. I'm sure Allison has many organizations in Tri-County who might want to be working with them. And so it might have sort of an internal folks who are part of this, but then also some external folks might join the table. Or it could be a rotating, the composition of the council might change, or the councils may change as issues change also. I'm also thinking about, we talked about having sort of use case groups or user groups, and I don't know where that would live or how that would come together exactly. But if there's 5 researchers, or if all the public health agencies are wanting to work on a specific issue and they've got different people around the table helping them with it, is there something that is that there's a sort of use case specific council also? I don't know if it's worth identifying that up front.
I think that's something that's been really valuable with HCSRN. That has generated a lot of helpful documentation is establishing a community of users. In their scenario, the users are also the contributors, so they're able to cover a lot more ground. But to Allison's earlier comment comment about the role of LPHAs. I think getting together the user community, not necessarily some of the non-technical people, but the technical folks will be really important because they will, just like Jessica said, they're going to poke so many holes in what we put together and think is like ironclad and perfect. They're going to figure out so many ways that this should be tweaked and polished and improved. And so that is important. That could be, I don't know if that goes in this document, but I think it would be important to call out. And that's where I think the training will begin, and that will become the user community.
So I have a question specifically about the Community Engagement Council. So I know in PCORI this is really a requirement in order to ensure that we're utilizing not only the PPRNs but also and partnering with those, but also to make sure that we have more or less a sounding board for how we do the things we do and how we conduct things. And so I never have heard that in relation to CHORDS, of actually either having projects that we're going to be kind of vetting against a community board to see how we should do them, or potentially changing our processes and the way we do things, or also partnering with projects that are already going on that are in the community. So I was just kind of wondering what really the purpose of that council will be.
Yeah, I think community engagement is a scary word, and I had the same response of, oh my gosh, are we doing that?
I guess I don't see this group right now as, I hadn't thought of them as having final decision, like, no, you can't do that, or oh, you better not do that. I think about the work that you all did a couple of years ago, perhaps, or maybe the BMI group did, where you brought community partners together and showed them the maps and said, what do you think about this, and what does this tell you, or how would you use this? Like, it's a little more of a, I wasn't thinking of it as like the yes-no happens in these groups, but this is more about these are the areas that we're thinking about working. I'm not sure actually what that dialogue would look like because I don't know who would be part of the group that's working with Tri-County on their public health improvement plan and their mental health initiatives or, yeah. So, but again, maybe
a different term than engagement, though.
Okay, that's good to know.
Maybe like community sounding board
or something. This is very portal specific because these are the councils that were in the proposal.
Yeah.
So yeah, it was for a different purpose for sure.
But I guess something to think about would be from the research side if that's important and if there is a need for something like that on the research. I don't know.
Those could be sort of ad hoc based on the research project.
Yeah, I think they'd be more project specific and not specific to CHORDS itself. So I think that's something the investigator would do, and then they might involve us. But
one thing this makes me think of is a group that used to meet, and I'm not sure if it meets anymore. So Deb Thomas works at the university. She's a GIS person. And like twice a year, there was a Denver metro area GIS user group, which is a group of people who are interested in GIS, where the new cool projects people were working on were shared at this group. And it was like a dissemination group that helped people understand what work was happening and what was available. And so I agree the word engagement is very scary and now has a new meaning that represents lots of work. But that there could be a lot of value in a place that meets, or a group that meets once a year, twice a year, and talks about all the new things that are available with CHORDS and the cool things that have been done with
Maybe not. Okay.
Yep, sorry. I'm sorry. I was on mute.
You were coming in and out. Does COREO have any sort of a community board or a community council? Is there any externally facing interface that you have with non-clinicians, non-members?
Not non-members exactly. Our policy group is our externally facing group, but that is composed of users, of COREO users. So the only other place where we do community-facing work is in a project that we're engaged in with the state to build a patient-centered portal for a particular group of Medicaid users, long-term service and support Medicaid clients. Yep. And we do have focus groups, 5 focus groups from across the state who are not engaged in any way with COREO, who we meet with regularly to talk about what their needs and desires and experience is with this patient portal that we're developing. But from that perspective, that their information is input for the development of this portal. It's not a decision-making body.
Okay, thank you. That's helpful.
Mm-hmm.
Is there anything else on this table of contents? I truly, as I mentioned, was only thinking that we would spend time looking at this top piece of organizational structure, because I think some of the other stuff, we still need to, we're not there yet. And some of the data infrastructure and governance, I think that we might have some existing documentation, but that also may be part of the group, the work groups. But any final comments on it, or you can send them to me by email before we move on to our last item of the day. Okay. So the last thing I wanted to share, and I kind of know, I don't here. So we're trying to do a few pieces around data sharing. That's why we're here today, and put together 2 new things for you all to look at. Folks on the phone, we're just passing around that Excel table that was sent out in the email earlier this week that is called the CHORDS Data Sharing Matrix. One thing that I was hoping that we could first do just as a level set is I've asked Emily and Rachel, if you all might be willing to just walk us through when we look at these data products, what do we mean by that? What are those exactly, just so that everyone knows? I think I'd like to hear from all of you. If you think that having something like this, Portal has developed this, if this would be a helpful document to have as part of our appendix for CHORDS for the governance plan. So
just to clarify, so we would have a DUA with, I'm assuming you, and then you would have these with other people, or how does that work?
So the data use agreement that we're revising, that I sent out a copy of, although that has not gone through legal review, so that's only gone through my review, and right, would be between the data contributors or the data partners and the public health agencies.
So we would have to have a DUA every time somebody wants the data?
No. The DUA has some really exciting and broad language that says this data can be used for infectious and non-infectious disease surveillance, as well as health behavior related something. So yeah, it's actually, I sent it on the email. I can send it out again, but it has like these categories around infectious or communicable diseases, chronic diseases, conditions or behaviors, behavioral health conditions. One question that we need to work through is whether we need to be explicit around 40 things that apply to 42 CFR. Because,
so the part that's confusing me is who is the who, not the what.
So it's one agreement for you, and there's 5 health departments listed on the agreement as recipients. So you would only have one DUA to contribute data to CHORDS just for the public health departments. Anything research related would require additional agreements that are specific to each study.
Okay.
So right, this isn't every time we share it, but it's just in the big picture of what documents need to be done.
And it describes exactly the parameters around the limited data set that make it okay.
Yeah.
So it's a blanket agreement. So we have to have, or we'll have 5 data use agreements.
One.
Okay.
All 5
one with 5 signatures.
Yeah.
Right.
Yes.
Right.
6 that's the goal.
6 signatures.
And the hope is maybe we could someday get to having all of the data partners All of the data users.
And that was realized in
We did it
in SPAN.
Supreme too.
Uh-huh.
SPAN and Supreme, we were able to do it. But these were partners that had worked together for years.
We're not there yet.
So, right.
And you weren't adding new partners.
But we could.
You could.
We set it up that we could do amendments
Oh,
to
good.
add other organizations.
Great.
So it's
But it
multi-party.
would require another set of signatures. But if the agreement would stay the same, that would be an appendix. So,
It's multi-party but not reciprocal.
right.
And that's right. So the content really has not changed dramatically. It's the signers who are on that in terms of the public health departments. And then trying to, whereas the previous DUA for CHORDS was like specific about BMI. Or
tobacco,
right.
depression, CBD, I think.
And so this is why saying chronic disease. Now it doesn't mean, I mean, there are only so many queries written, and so obviously it's not going to suddenly mean every chronic disease will be available for queries the minute it's signed. But so that helps.
So what about people who don't fall in any of these categories?
Who would that be? Or the same
So lone public health people who are not part of an agency, or all these 30 other.
These other that we just talked about. Yeah, see, since they're sort of not in the mix yet, we didn't have them in there. But that's
so. Just to kind of something that I've experienced with other projects is that sometimes to simplify things, it's easier to have one site, and for lack of a better term, I'm going to call it as a broker. So you'll have a central site who everybody has an agreement with them. That agreement allows them to go into additional agreements with other agencies to provide that data, so that every time somebody who's not on this chart asks for it, or every time a research asks for that, we can have that just one DUA with the kind of central group, rather than every single data contributor having it.
so I think, and Kate, correct me if I'm wrong here, I mean, in some ways that's sort of the Korea model, because they're the central hub, and I think that long term that would be ideal for operationalizing what we want to do in the next year. We're not there yet, but that's an important thing to call out, which I've made a note of, and that's something that we should probably be thinking about sooner rather than later, just as we're thinking about what do we do today, what do we do in a year, what do we do in 5 years.
Now, does that align with the notion that we continue to reiterate, which is no one stores all the data and it remains at your site? Okay.
Yeah, that could still happen. So, because this actually came up with another project, or actually with the core projects, where we have a data coordinating center. We all have a contract with them that allows them to give our data to CoreNet. But then CoreNet sent an agreement, and the data coordinating center asked us to sign that agreement. But the problem is because in that case, we're not even the ones who are providing the data. It's the central coordinating center. So it didn't make sense at all for us to sign it. So our institution would not sign because we are not exchanging the data ourselves. In this case, we are still exchanging the data, but at the same time, I could just see, so our site can take 5 days to 5 or 6 months to get the DUA signed. And so I could see this being an extremely lengthy process for us to have to do this for every single research or at every single site. So I think that could be a bit of a problem.
I would say for today, I mean, maybe we should set the research idea of for every single research study. You know, that's probably a different conversation, but for the purposes of the moving public health forward and getting, I think that's what's so nice about the public health agreement, having the blanket coverage there.
Yeah.
That way, 6 months. Then it's done. Yeah.
Kaiser have some way to standardize the DUA to make it easier across the project?
We base almost all of our DUAs on the Healthcare Systems Research Network template.
Yeah.
So everybody has seen the language. Everybody has signed at least one agreement. Probably lots more based on that language. And it's also tied to the contracting piece, which makes it nice.
I'm just wondering if that's a model that we can just use here.
Well, the current DUA, the current one that we're revising is the one that all of the data partners have already signed or have signed some version of with Denver Public Health as a starting point.
Okay. And we were able to get that blanket language through Kaiser. Kaiser's usually our litmus test because they have and children's. So we'll see how it goes. If we get through your legal, then no one's going to have a problem with it.
Data products?
Oh, yes. So was your suggestion that it would be helpful to create a column for community partners and just have some
who doesn't fall under that?
Yeah, so everybody else who wants data, and maybe we'll have some nice language there that says we'll submit requests to public health agencies in the future and have no direct access currently. So data products, the quality assurance tables. I think this is data quality information about your own site's data. That's number of visits per day over time, number of people per day over time, demographic breakdown, number of lab tests.
I also had could show things like number of records, missing address or geolocation, information, thinking about BMI, like number of records with invalid heights or weights, or like numbers that, is it like 2 standard deviations that you guys throw out?
Oh, on the BMIs?
Yeah,
yeah,
like
number of,
those type of,
yeah.
that type of information with QA also.
That are like possibly outliers.
Yeah.
Things that don't make sense. And there's like some kind of sanity checks that PCORNet has pioneered, like number of procedures per visit, number of diagnoses per person. That if you have, I think that we ran into an issue because if you can't get at least 1 procedure per visit, that something is wrong. So,
dark gray mean that we will not give it out?
So that was my current thinking on that, but does that make sense that really only it's the data contributor that's doing that?
Yeah. So I think it depends because, I don't know, and for our PCORI grant, we are providing that data publicly so that people can know if they can trust the data or not.
So it's a requirement of participation in PCORNet is submitting those. That's the way they monitor data quality and kind of say that you're ready for research or not.
Yeah, and we're doing additional ones in addition to what they're
the data characterization stuff?
Yeah, we're doing things that are what we consider investigator needed information in order to determine if they would want to use it.
Today, for public health, CHORDS has been doing this. The data partner does her own.
One would hope, yes. Although it's something we've really struggled to do. It's really.
We shared some scripts too, right?
You shared the ETL.
Well, no, but before it didn't. Was it David that created?
So David wrote some basic counts, some SQL programs that said how many procedures do you have in your procedures table? What days are they on? Do you have anything that's glaringly wrong? But I think we would need to step up our game as we, in a lot of ways, the height and weight and BMI thing is relatively resistant to a number of data quality issues because of the way it's calculated. And so as we move into things like diagnosis codes, it would be important to think more about that.
When you say we, who do you mean by we need to step up our game?
I don't know who I meant by we.
Data partners? Royal we?
Yes.
Okay.
This is something that we have Carter, who is our data analyst who just joined course over at the university, and he's we only have a couple hours of his time, but that was one of his first things, is looking at David's quality assurance data tables, and then also the ones from, what group are the other ones from?
That's the data characterization program from PCORI.
From PCORI. So he's looking at those, and he's kind of thinking about QA and some good questions. And so, anyone have QA ideas?
Sarah brings up a great point, though. It just dawned on me all of the things the Data Coordinating Center in PCORNet does. So many things.
Who knows the most about the Data Coordinating Center at PCORNet? Other than the Data Coordinating Center? Truthfully. Well,
probably the two of us.
I guess let's think through sort of do we have a strategy for what we should be looking at?
Does Michael Kahn work with them?
Yes, because he's the one who told me that they refer to them as the door knock. Yeah. It's DRNOC.
Okay, so maybe we'll follow up with. I'll follow up with Michael. Okay. We have 20 minutes, so I just want to sort of think. Does it make sense to keep this in here, that we have these quality assurance data tables as part of this?
Yeah.
Okay, great.
And we might be, it might be gray right now, but they might not be gray in the future.
Right. This is all sort of current state, and there's a lot of holes in here because I just didn't really even know what to put.
I was actually going to ask next what the white meant.
Yeah, because I didn't really know what else to put in there. I mean, I'm sure it should all say data use agreement, where it doesn't say, like, I was going to shade out like the public health agencies for individual identified record level data sets, because that's not really in, I mean, yeah, the whole row of identified record level feels like it just needs to say partner specific. But then again, I didn't know, because one of the things we talked about when we were going back and forth on this is that public health has access, or could potentially have access, to certain identified record level data sets for public health communicable disease stuff. But that's not really been a use case for CHORDS before. And so that was one of those things where
there's another system built in.
Yeah,
right.
It's called CEDARS. We don't ever need to do that.
Okay, I
had a lot of regulatory.
Yes, that is just for people with stuff you don't want.
Well, but it's, so this is the back and forth with Art, and I think it was not so much certain pieces that, but like if there's an outbreak of something.
So the minute you start talking about CEDARS, that makes my little heart go pitter-pat. I'm just gonna, my little regulatory heart goes pitter-pat.
Yeah, and CEDARS are things like HIV. I mean, those are, what goes into CEDARS?
Oh, hold on. It's the electronic disease reporting system. So anytime there's a positive lab result for any of 69 reportable illnesses as defined by the Board of Health of the state of Colorado, a provider or LabCorp is required to create a record, which goes to state, is assigned to county, and then it goes to a county nurse who calls the person and said, where did you buy your steak?
Okay. All right, I'm just going to shade that out for right now.
Well, yeah,
go back over.
I would hope they go to hospitals and not to us.
Very protocol. Yeah, right. That was sort of, but
was our thought that this could provide information for outbreaks in the future?
I am writing what he said. We've not yet played out that fully identified patient data use case, but it has been discussed at a high level with regard to hepatitis C and HIV. It is not in the near future, but once CHORDS is in full play, I suspect these two use cases will return to our attention. I think we should add another line for identified information, and so we did. We don't need to talk about that now, and he's not in the room, so I don't want to you invoke his name. But so that's why that's in there, and that cell is not shaded out.
So that's different than CEDARS.
Go ahead,
yeah,
Kate.
I would call that like electronic case reporting or something, and set that aside, perhaps.
So HIV, some of it goes into CEDARS, but not much. New cases of Hep C do, but that makes sense why he said that. And maybe there's a way for us to start thinking about describing future states.
Got it.
And things that could possibly be available, but those are so complex. Those diseases have like their own laws about them.
Any other, I guess, what else do we want to talk through in terms of the data products and the data consumers in our last 15 minutes?
So I would actually think that we would provide researchers with all the same things we would provide public health agencies with. So I mean, researchers a lot of times want de-identified or limited data sets, so I think that we should have that information relayed over here. The one thing I'll say from my hospital in particular, we will not sign DUAs for the first two listed for DUA because those do not qualify for DUAs under HIPAA.
They're not needed.
Say more about that.
It's not needed, and our hospital will not go into an agreement that's not needed.
Sure.
It violates the...
You never want to be audited on something you're not supposed to
exactly. do. So our hospital would not do a DUA in those cases. They might do a data sharing agreement of some sort, but they will not do a data use agreement.
Because the DUA is specifically for a limited data set.
Right.
Or a data transfer agreement, I think.
I think institutions.
Each institution has their own.
Yeah.
So I think that as many times as when we're talking about agreements that allow sharing of de-identified data sets, I think we should just say data agreement and not say data sharing, data transfer, because organizations use all different terms. But when we talk about sharing limited data sets, we do need to specify a data use agreement.
So what would we need to do? How would we operationalize this? Like these aggregate summary data tables could be something, again, this idea of do we have sort of standard products that we're always turning out? Is that, how do you...
So if we're making it publicly available, then we don't need any agreement. If it's something that we aren't making publicly available, but we have, none of the cell counts are too small, then I would think that we may or may not, depending on the institution, might want a data sharing agreement or a data agreement, sorry. And then for de-identified, same thing. We, at our hospital, a lot of times we say, well, if it's de-identified, we don't really need anything. Now, a lot of times, we're getting paid for doing the work to make the de-identified data set, in which case we'll throw that into like if we have another agreement or a subcontract or something like that, we'll build that language into there, but we never have separate agreements for de-identified data sets either.
And I think it's going to be institution specific.
I agree.
I hate to say that.
Yeah.
I think that that's kind of just the way it is.
Yeah.
But Kaiser would be under that same de-identified or aggregate.
Yeah.
You wouldn't need a data use agreement.
So when people request data for the BMI registry project, like DEH, do they sign anything before they get the results, like the aggregate tables? Do they don't like read rules and sign a participation agreement? Okay. Are there guides?
Data. No.
Right. Are there any recommendations about how it should be used or interpreted? Okay.
Yeah, there is some disclaimers
Mm-hmm.
that goes on there.
Mm-hmm. Okay.
It's like just a passive system, basically.
Mm-hmm.
And they sign that by participating?
They don't sign anything.
They don't. They just know that as part of being part of this project, these are the ways in which.
I feel like there was an email trail this week that said some types of aggregate tables are limited data sets.
So it is if it has small counts or if it has geographic information that's smaller than a zip code. Except for geocodes, to some extent, some geocodes are not considered.
Isn't a census tract, you can go to a census tract for a limited data set?
Yes.
As long as the census tract has more than 500 people?
I think something like that. Our HIPAA officer found the actual regulation. I might still have it. I can see if I can find it.
I got it too.
Do you?
Yeah.
So we should split out aggregate summary table, like aggregate summary table that's protected or the
Or considered de-identified.
considered de-identified, and then aggregate summary table that it may include geospatial information or small cells.
Yeah, and then there's also age requirements. So over the age of 85, either has to be greater than 85, or if it's individual years, then it's considered identifiable. So if you say 86-year-olds, 87-year-olds, 88-year-olds, that's considered identifiable.
There's a lot to know.
Yeah.
Okay.
I really think we need to have a HIPAA expert.
Oh, we will. We will. We're putting a contract in place with Comcast.
Okay.
We just haven't finalized it yet.
Okay.
So, if that's, and I know that this isn't done.
Right.
But
yeah.
So just so you know, on the data sharing matrix, this is exactly why we put the HIPAA language at the bottom of
Okay.
it. This is exactly the reason.
Got it.
Because people would ask questions, can we share a zip code?
Okay.
Well, you can if. So, I mean,
So in some ways, we maybe just sort of lift that in its entirety
it's
almost.
government
Okay.
language, I would just-
Okay, great. Thank you.
And we'll need to think about, we have urban counties and rural counties in this 5-county area. So the rules will, so in Denver, there's no census tracts where they're going to be too small to share.
Right.
But in Douglas County, there might be. So if your census tract is too small, if there's 10 people that live in your census tract, then it has a different rule. And so that is, an added layer of complexity. So maybe then in those aggregate summary data tables, like the Denver information is in the census tract, and we just make like a blanket decision about, or recommendation about the counties, or it's county level information.
Yeah. So I'm trying to think through here. So do we need to have two, because there's not currently a data sharing agreement in place for CHORDS. There's a data use agreement with the data partners and Denver Public Health.
Mm-hmm.
We need to update the data use agreement for these record level data sets for all of the public health agencies. Do we need to create a data sharing agreement that also, or is that something that gets defined in the governance plan that as a data participant, or as a participant, these are the things that are assumed you'll provide?
Well, I think that the data participants need to talk to their institutions and see if they want an agreement.
Okay. What would children say? I mean, not holding to this, but
children's, I had to arm wrestle with them to get them to sign a DUA because they're like, well, if it's under public health, then we don't actually need a DUA, right?
True.
So.
Okay.
I said, can we just have it signed, please, so that we have some documentation?
And so that's a great question too, because if that, if there are queries coming in and they're landing in Greg's inbox, does he need, sorry, there's another Greg. What information does he need to know about, like, this one doesn't have an agreement and this is okay?
Yeah.
Yeah.
Yeah, I think we need to know who it is, what they're, and like not specifically necessarily, well, I guess specifically yes, but we need to know like what their role is. Are they a public health agency? Are they a researcher? And is there an agreement in place? If so, what kind of agreement?
Mm-hmm.
That's all the information we need. Mm-hmm. Well, there's probably more actually.
So we're just circling back around to the data exchange requirement.
Yeah, we actually, we have one, the Cordy DSA, that we gave some input on, and I'm trying to see if I have the most recent one. It looks like this one's older that I have. But we actually ended up doing a big matrix too for that.
Mm-hmm. If you have anything that you've used that you're willing to share, that'd be great.
I don't know if we agree with everything
to start with. Okay.
Yeah, and actually I can even ask one of our lawyers to take a look at it and tell me if there's anything he doesn't.
So is that an action item for all the data contributors that currently exist? Is a question about your internal policies?
It will be.
Okay.
I think that data contributors, tell me what you think about this. I think if we can combine the asks of them around agreements, that would be helpful. And so when we have the data use agreement updated, the irony that we might have an easier time exchanging record level data as opposed to aggregate, and then ask them to review that and sign that, and then also ask them to review the internal policies around data sharing agreements for aggregate data tables, which will give us a little more time to specify exactly what we mean when we say aggregate and de-identified data tables. Make sense? Mm-hmm. Does that seem like a good strategy forward so that we're making one ask of the data partners when it comes to...
So it's interesting, I'm just looking at the draft DUA, and it says in that fifth paragraph, the fifth whereas, it does mention de-identified data sets. So I wonder if that was a way to make it encompass both.
That's in the data use agreement?
In the draft one that was in the
draft data use agreement. Yep.
And sometimes for our institution, you know, we write this into the contract language, so we don't have to have a separate data agreement.
Okay.
We'll write it into the subcontract. So I think different institutions do different things.
So maybe that's the question to the data partners. Here's how the contract looks, calling out that we've specified both limited and de-identified. Will this work as it is, or do we need to do something? Do we need to pull out de-identified?
Yeah, for our institution, if we wrote anything into the subcontract, it would take care of the de-identified part. It would not take care of the limited data set sharing part. We would need to sign it. We would need to sign a DUA.
Yeah.
So
we might make it a attachment to it in that case, but yeah.
And I think that the one between Denver Health and Kaiser has a little more detail in the attachment. Maybe.
Is that the new one that we?
So the new one has specific language that says, well, it describes the limited and the de-identified data set because we wanted it to include substance abuse data. So it said we will share limited data sets that include these things, and we will share de-identified data sets that include these things.
So is this a brand new data use agreement, or is this based on the language that we used on the previous one?
It's
the latter.
Very similar.
Yeah.
Okay. Yeah. I don't remember how much we changed it. But.
Do you have access to your current data use agreement?
I'm sure I do.
From your files? If you want to send that over, I can do a little crosswalk and show you what looks different. And again, until we get sort of the lawyer to look at it, I don't want to send it out, but okay. Okay,
I know we removed some diseases just because they were adult-only projects.
Yeah, like cardiovascular disease.
And also mental health, so because they were a little nervous about mental health. But our privacy officers changed since then, so hopefully this new one.
And this is much broader language.
Yeah. This just says behavioral health conditions. We've actually had some conversations already. My colleague in that office, there's a lot of interest in understanding these around pediatrics.
Right.
So I wonder if we should maybe even do a little offline just to sort of bring you up to speed on what people are interested in.
Yeah, definitely.
How we can, because I know that's been an issue in the past. Like some of this has really been more about adults, but I think there's a lot of youth and young person.
Yeah.
Whew, okay, Greg, welcome.
Ready?
You ready to start by fire?
This is the rabbit hole of data sharing, and it never ends.
Hopefully we didn't get too far down. So our next meeting is at the end of September. There will be some interim work in the meantime with the work groups. And thank you for everyone who said that certain things at. We're recording this, and so it will go. We'll circulate the recording to everyone, so you have the file, and then we'll eventually have a place to post it, because there's a lot going fast and furiously, and Ian has jumped in Maggie's absence to take some notes. So
thanks, Ian. Was this the best meeting ever?
This was even better than yesterday.
Thanks, everybody.
Thanks, everybody.
Well, thanks.
Yeah.
Thanks for your patience with me being late. I appreciate it.
Thanks for joining us, Kate. We'll talk soon. Thanks, everybody on the phone. If it doesn't work well on the phone, give us feedback.
Yes. Yeah, you put it in the box.
I think I sent it